right. Great to see everyone else. Hey, Yasmin, nice to see you. Elena, Johan, Anmol, great to see you guys. Welcome. So, son, why don't we, or I guess let me ask if anyone wants to join me and Zaven in kind of thinking out loud and sharing thoughts on Sosan's case. Yasmin, is that's a yes? All right. Anyone else interested in kind of unmuting throughout and sharing thoughts? All right, well, we can just tag team together. Elena in the car, but next time, no worries. And here's Zaven. Hey, Zaven. We can be able to
switch the audio to the thing.
Give us 1 second while we sort out our IT stuff.
Let's do the Logitech webcam.
Mm-hmm.
And then same with the sound. Speakers. Have you tried that?
The second one or third one?
Second one. Okay. Can y'all hear us? Okay. And can somebody say something and see if we can hear you too?
Yeah, we can hear you loud and clear.
Okay.
Can you hear them
Thanks,
too?
Lisa. Barely.
Should I take this out?
Yeah. Let's try it.
Guys.
Yusuf, can you? Oh, hi, Yasmin.
Yep.
Okay, perfect.
I think we got it. Okay, cool. So Sosan has got a case for us, and the group is our set of allies. So Sosan, if you want to take it away, we'd love to hear about the beginning of the case.
Okay. So we have a 38-year-old male who was admitted due to severe anemia. And I'm going to stop here.
Okay. And actually, I realize we need, I don't know who's scribing today. Let me make sure you are a co-host. You can share the screen. Yusuf, were you scribing or was it?
It was Johan.
Johan, thank you for reminding me. There you are, Johan. Okay. And teaching points was Anmol, right? So let me just make sure you have access.
Please,
Great.
Anmol, can you share your screen?
Showing my rustiness with the technicalities of setting this up. It's been too long with you guys. It's good to be back.
I'm excited about this case. It sounds fun.
So you said this is a 38-year-old man with severe anemia. Sosan, yeah?
Yeah, that's true.
I'll just share kind of first reflections. If you had said instead it was a 38-year-old woman with severe anemia, I wouldn't have been probably as surprised or maybe quite as worried off the bat. Because obviously women with menstruation are really at risk for often very severe iron deficiency with anemia with that. But a young man who has this, I think immediately worrying about where he's losing it, either out of his body or whether things are being destroyed, or if there's really a severe production problem. I think we really have to open up our anemia schema right away, knowing that, iron losses from just regular monthly bleeding are really not going to be a risk factor here. Do you have any initial other reactions to hearing that?
I just quickly, both what happened in my brain as well as listening to just a few sentences from Steph, made me, you said anemia schema, right? But even you immediately deployed more than one anemia schema. And Robbie's so amazing at this, at having multiple approaches to the same problem, right? So you used an epidemiologic approach first. Young woman with anemia, you're not even thinking, right? You're just starting with a ferritin. A male, suddenly the epidemiology is much more mixed, right? There's not like a predominating cause, so you need a different schema. So you deployed your destruction, hypoproliferative sequestration, whatever, that schema, right? For anemia, just like with everything else, time course is so important, right? So if it's chronic versus acute, that's an important branch point of, with acute, you're thinking either bleeding or hemolysis, right? With chronic, the whole world is open. And then you could use the MCV, right? There's yet another schema to think about categorizing anemia as small cells, big cells, normal cells. So I think it's just a good example of how you can have multiple schemas that are either more appropriate in different settings, or that, you know, all of them will probably get you to the right answer, and it's sort of dealer's choice. And or if you get stuck in one, the other can be helpful. So just a good reminder how it's good to have kind of multiple approaches even to the same problem.
Can I add, Elena, I love your comment about symptomatic anemia or not being another really important early decision point for, you know, we don't know this person's past medical history, but if they're otherwise healthy, they're going to have to be pretty anemic in order to actually have symptoms of exertional dyspnea, chest pain, etc. And then I love your point also, Elena, about is that the only cell count that's down, or is that just when this person first meets the healthcare system, it's the most predominant one, but there's signals other places in the CBC. So some beautiful points.
Amazing.
There.
That's like 7 or 8 different, right, like kind of approaches or schemas.
Too numerous to count on the schemas here. But Sosan, tell us more.
Great discussion and introduction. So for the HPI, the patient started to have symptoms about 1 month ago, where he noticed easy fatigability and generalized weakness. And his wife also noticed that he looked pale. And 1 week prior to presentation, he developed a dry cough. And a few days after that, he went to the nearest dispensary and got a CBC and a chest X-ray. The CBC showed low hemoglobin, and the chest X-ray showed widened mediastinum, but without any consolidations or features of pneumonia. The patient denied having any constitutional symptoms like fever, weight loss, or night sweats, no bleeding from any body orifice, no history of trauma, no family history of bleeding disorders, and he has like no past medical history. He works as a salesman. He doesn't smoke, and he was referred to the hospital for admission and blood transfusion. And I'm gonna stop here.
Quite the aliquot. Juicy. Yasmin, I don't know if you want to jump in. We've got so much additional story here, symptoms, imaging already. What stands out to you, and where are you thinking?
Oh, thank you. First of all, thank you for this. After listening to the widened mediastinum, the first thing I was thinking, well, blood loss is something that we have to look for in a patient that has a severe anemia. Otherwise, think about, hey, are there like RBC destruction or RBC issues, like issues in production? But now looking at the widened mediastinum, there is a speed dial schema that Maddie and the schema team created of the thymoma, teratoma, cerebral lymphoma, and thyroid issues. So in this one, like Venn diagram, what makes me think is look for signs of lymphoma or any blood malignancy. So that's the first thing in my mind, like where is this issue? And then we can go over the different mediastinal like regions, anterior, middle, posterior. Anterior, again, these are the speed dial terrible T's. In the middle mediastinum, we find lymph nodes, we find vascular abnormalities, we find neurogenic tumors. In the posterior mediastinum, we also have mostly neurogenic tumors, being like from all this nerve structures, or even other non-neurogenic like the chondrosarcoma, but those are like very obscure in my mind. So the first thing I would do is look at the CBC and look for blood malignancy.
Wow. That was so good. What a beautiful review and anatomically of the mediastinum. I really can't add anything to that. It was so beautifully done, Yasmin. That's awesome. So, Son, what else can you tell us?
Okay, so for the physical examination, the patient was afebrile. His heart rate was 110, respiratory rate was 17, blood pressure was 128/76. The patient looks ill. He had conjunctival pallor. He had bilateral palpable cervical lymphadenopathy and no jaundice and no hepatosplenomegaly and no petechiae, purpura, or ecchymosis was seen on examination. Otherwise, nothing else was seen or like was found. Would you like me to give you some initial labs, or should I stop here?
Thanks, Sosan. I don't know if this is coming later, but I'm left a little bit just wondering if like the rest of the history was basically like unremarkable, like no other past history, no meds, like or if that's coming later.
No, no, he didn't like. He doesn't have any relevant past medical history or anything else.
Cool. Thank you. Yeah, I think the exam is really important in that, you know, it sort of confirms that there is some kind of neoplastic process likely, maybe an atypical infection that's disseminated in both in the mediastinum and the lymph nodes, but definitely kind of puts that in that world of there's a primary process, and then anemia is secondary from that, either via hypoproliferation from inflammation, though inflammatory anemia alone usually doesn't. Wait, did we hear a number for the anemia? Or?
Not yet.
Okay, not yet. For some reason, the hemoglobin in my mind was 4.8. I don't know why, but anyway, either inflammatory anemia or bone marrow infiltration, or a lot of hematologic malignancies can trigger autoimmune hemolytic anemia. So that's still sort of something you don't want to miss as a process, both potentially to stop intrinsically and appreciating that it's going to be much more volatile than hypoproliferative anemia in terms of getting worse and potentially requiring life-saving supportive care transfusions, et cetera. But I guess short of guessing what the hemoglobin is or hallucinating it, yes, would love to to see the CBC.
Okay, so the hemoglobin was 5.5, MCV was 103, the reticulocyte count was 9%, the white blood cell was 24.16 with a neutrophil predominance, but also the lymphocytes and monocytes were mildly elevated. Platelets were normal. The LDH was around 400, mildly elevated. Total bilirubin was 31, with the normal range is 22. The direct was 15, and the normal limit is 10. And the haptoglobin was less than 20%. Yeah, it was low. Yeah, less than 20%. Should I stop here, or do you want further information?
I think we've got some good information here.
So just one thing for the billies, I'm guessing the unit here is milligrams per liter, right? And you said the upper limit of normal was 10.
Yeah.
Okay. So in my mind, I just have to translate that to just divide everything by 10, because in the US we're used to milligrams per deciliter, so the upper limit is 1. So in my mind, that billy is 3 and 1.5. And that's important to me because I got really scared that he, just had horrible liver failure or something. But okay, thank you for clarifying that.
Yasmin, what's sort of your approach to tackling this CBC that we have?
Okay, so first of all, I see these really high white blood cells that even if I really would like to say infectious, because there are some infections that can cause hemolytic anemia from viruses like hepatitis, CMV, EBV. There are other infections with malaria, trichoderma, brucella, babesia, and trypanosoma, among others, that can cause hemolytic anemia and can present with high white blood cells with, if I'm not wrong, neutrophilic predominance. This quite high count will still prioritize looking for malignancy. And I think that my next step would be do a blood smear. I would definitely like to know if there are any signs of like oval macrocytes or hypersegmented neutrophils in this case, looking for any other clues that can help us like give us a differential prioritized differential diagnosis in this point. We have I thought I have heard it's TBILI of 31. So I am also looking at what can be happening in the liver. But I would definitely like to know what you think, Dr. Steph.
Yeah, that was excellently done, Yasmin. I think I'll be honest, the neutrophilic predominant leukocytosis, I am, yeah, I think you brought up a great list of potential infections and drivers of that, but to me, that's not bringing any weight, any particular direction. And this anemia with the macrocytosis, I think is just bringing to mind, we have a whole differential diagnosis for what elevates MCV from the megaloblastic conditions. I think that's a great point to see if any of those neutrophils are hypersegmented to alcohol related. Someone asked about alcohol history in there, and then other, pathologies, bad thyroid disease, liver disease, etc. And then reticulocytes, when they're being made, are bigger and juicier. It can help bring the MCV up higher. And that reminded me, Sosan, to ask you, this reticulocyte count of 9, that's an uncorrected reticulocyte count? Do you know if the index was high or not? I just want to make sure I'm interpreting that normal correctly.
It's 9%. It was elevated, more than 2. Yeah, the
Okay,
index.
thank you. Yeah, because we've got hyperproliferation here. So our initial worry potentially about bone marrow infiltration or hypoproliferative processes sort of put to rest, because actually the bone marrow is doing what it can, right? Pumping out early red blood cell forms here. So it really puts us in that destruction category with the hyperbilirubinemia, the modest LDH elevation. I think we really need to think about mechanisms for destruction. And there have been some just great points from several people in the chat here about getting a DAT test to begin with, which I think we don't have yet, to sort of get into the autoimmune destruction pathology or not here. Other thoughts you want to add on this data we have so far from the CBC?
I just loved Yasmin's opening kind of idea about not, I was very anchored with like the lymphadenopathy and maybe the initial thoughts about right a neoplastic process, and her acknowledging that yes, that's possible, but more acute, potentially more actionable, and definitely a no miss process is an infection that is triggering hemolysis, and that was an impressive list of possibilities you rattled off. But I think at this point, like the differential on the white blood cell is really important. Looking at the smear, absolutely, but even real quick, like if it's mostly, it's almost 24,000 neutrophils, just in terms of that differential of infectious hemolysis, because you're kind of thinking, hemolysis, the lymphadenopathy is still there. You need to explain it, and what can create such significant neutrophilia. So, for example, the monoviruses, I think, would usually not, right? Malaria, lymphadenopathy, I don't know. I need to sort of buff up my illness script real quick. I don't associate necessarily with lymphadenopathy. So I think if you try to triangulate those 3 kind of key features of the case, then it might help to narrow the differential a little bit. But going back to that and sort of coming up with a more comprehensive list of sort of infectious causes of acute hemolysis, and then using the lymphadenopathy as a filter, as well as the neutrophilia, might help to zoom in.
Excited to hear more, Sosan.
So we ordered a blood film or like a blood smear, which showed normochromic normocytic anemia and no abnormal cells. HIV and hepatitis serologies were negative. And Coombs test came back positive +3, both direct and indirect. And they showed like both worm and cold antibodies. And we were about to transfuse the patient, but no compatible blood was found until now, like at that time, due to the antibodies. So what do you think about having mixed autoimmune hemolytic anemia? Like, what does it change for you?
Mixed being warm and cold.
Yeah.
Not an area of strength, I will say. I do think it's just kind of continuing on the thought of like suspecting infection and hemolysis. For the reasons mentioned above, those other kind of features we're seeing, the mechanisms can be, I think, direct erythrocytic infection and lysis, such as in, malaria, in babesia, in trypanosomiasis, in, clostridial sepsis, or it can be infection triggering immune hemolysis. I think that's the case with most viral infections, in mycoplasma, I believe. So I think that's another kind of set of information we receive that's already helpful, just the fact that it's immune. And if we're still sort of thinking of the lymphadenopathy and the neutrophilic as kind of making a suspect infection. As far as cold versus warm, like I said, my memory on that is shaky. And I don't necessarily have, it sounds vaguely familiar that there's something distinctive about it being both, but I don't have the answer in my brain of what it is.
Yeah, Yasmin, can you help us out at all? Any thoughts on how to think about that dual finding?
Yeah, like honestly, when I was like trying to create a differential diagnosis, prioritizing something. When I heard Coombs direct and indirect, both of them being positive, first it tells that it is autoimmune hemolytic anemia. What is triggering it? I am really wondering if this patient, I would ask this patient in real life, like, have you been treated with any drugs before? Have you taken, even there are like even penicillin, or did you have any type of infection before this that can trigger autoimmune hemolytic anemia? Something that shows us like if the indirect Coombs test comes positive, we know that there are like free circulating anti-RBCs antibodies, if a step 2 is not failing me like right now. And what we want to know is that what is causing, first, that there are antibodies against RBCs and there are receptors in the RBCs, like antibodies and receptors, both of them. So what is triggering it? Maybe a drug, maybe an infection. I am still prioritizing malignancy, looking for myelodysplastic syndromes, acute myeloid leukemia, because this patient is young, or again, lymphoma. And I think that the next step, I am really wondering what to do next. So what do you think?
Go ahead.
I think I'll say one thing, a peripheral smear, just in terms of like what, with warm autoimmune hemolytic anemia, right? The very typical finding is sort of spherocytes. Is there one predominant process over the other? Actually could be helpful, and perhaps the RBC morphology can help us there. But otherwise, I think just the immune activation is sort of the key piece that we're getting to here.
And I think, the, sorry, Steph is stepping out for a second just to get some water. But I think I don't, to Sosin's question and my kind of happy admission that I don't necessarily know the answer to what is the significance of this pattern of antibodies we're seeing. I don't feel bad about that because I think it's recognizing that it might be significant, and again, using the resources we have in the point of care. So I'd love, I haven't been able to keep up fully with the chat, but can people look up and tell us like what and help answer Sosan's question of what should we consider if there's warm and cold hemolysis at the same time?
Should I proceed or should I wait for Dr. Steph to come back?
Let's give her one sec, and we can just kind of keep talking a little bit. Or I'm curious if what people do to just hear more from folks in the chat. So Andrew, are you saying it's supports a potential lymphoproliferative process just because it's sort of like a heterogeneous, like a multiplicity of types of antibodies being produced, or sort of a heterogeneous kind of immune activation?
Yeah, Zaven, I'm just thinking of, if you were to do it in SPEP, you see that polyclonal hypergammaglobulinemia kind of signifying, kind of chaotic antibody production. And, it would be a clonal process, but you can still spit out a lot of different antibodies that can be pathogenic.
For sure. Might be wrong in this, but I think the monoviruses can cause a similar kind of chaotic immune activation. Typically I associate them more with warm hemolysis. That may or may not be correct, but something's telling me it can be either or both too. Okay, so please, you can feel free to take us forward if you feel the time is right.
Okay, so the patient was started on high-dose methylprednisolone for 3 days, but showed no improvement, and his hemoglobin further dropped to 4, and he became more symptomatic, having shortness of breath and palpitation. And during his hospitalization, a CT chest was done, which showed mediastinal and hilar lymphadenopathy. And for that, a true-cut biopsy of the right supraclavicular lymph node was done, and it showed atypical lymphoproliferative cells. And the immunohistochemical stain was inconclusive, and they recommended doing an excisional biopsy. And after consulting with surgery and anesthesiology, they weren't very comfortable doing it right now, as the patient doesn't have any compatible blood, and he has low hemoglobin. So they only proceeded with a bone marrow biopsy and aspiration, which showed erythroid hyperplasia and no abnormal cells. And that's for the 4th aliquot. And the 5th will reveal the final diagnosis.
The other day, I I, like probably most people, have been using ChatGPT and Open Evidence and other large language models, and just in a point of care, just very much more efficient querying of the literature, right? And it's just amazing how helpful versus less helpful these tools are, depending on the prompt, and specifically depending, like when it comes to like generating differential diagnoses and solving clinical problems, just the degree to which the problem representation, the right problem representation, identifying crystallizing the problem we're trying to solve, helps us and AI to solve that problem. So I think in these challenging cases, always a good practice to pause and come up with a good problem representation. So let's everybody do that, and then we can, after maybe about 60 seconds, please share in the chat, and then Yasmin, maybe you can offer yours as well. But I'm gonna work on it myself.
Definitely. So as I see it, we have a 30.
Yeah, Yasmin, do you mind just like giving everybody 1 minute to try to like
Of
kind of
course.
come up with one, and then you can share. Yeah.
Definitely.
Okay. Would love to see a couple of versions in the chat, and then Yasmin, please go ahead.
Okay, so should I give my problem presentation? Okay, so I think we have a 38-year-old male with a 1-month history of severe anemia, easy fatigability, and generalized weakness, presenting with a widened mediastinum on chest X-ray. On laboratories, presents elevated white blood cell count, neutrophilic predominance, macrocytic anemia, elevated LDH, positive indirect indirect Coombs test, high direct bilirubin, and the cervical lymphadenopathy biopsy shows atypical lymphoproliferative cells. So in this case, in my differential diagnosis, what I'm prioritizing is a lymphoproliferative disorder, being a lymphoma in the first place. Then again, the acute myeloid leukemia and the chronic myelogenous leukemia are in the second place. Something that we can also consider would be, for me, having, of course, a widened mediastinum, lymphadenopathy, and the systemic syndromes. A very obscure cause could be Castleman's, but I'm still like, I think that's a stretch. And yeah, like again, thinking what can be causing this, what can be triggering this, an infection, just because I like thinking on those differentials. I mean, EVV, CMV, HIV can cause those kinds of presentations for can trigger, the lymphomas, non-Hodgkin specifically, but those are my differentials.
Love it. Thank you, Yas. Anmol, a 38-year-old, previously healthy. So hemolytic anemia, diffuse lymphadenopathy, and I would, just, and then we have this pathologic finding in 2 places of, lymphoproliferative process without obviously abnormal or malignant cells, including in the bone marrow, and then the erythroid hyperplasia, just kind of reflecting really just bone marrow response to peripheral destruction, right? Steph, how are you feeling? Is the cough drop kicking in?
It's kicking in, yeah. Catching up here in the chat.
So we're just doing a problem representation, and the newest piece of information was basically you heard about the supraclavicular biopsy, and then the bone marrow, no atypical cells, just erythroid hyperplasia. I think kind of 3 categories of disease. Well, maybe starting with 2 is I was just learning from Andrew there, and about just being reminded of this angioimmunoblastic lymphoma. So I guess like a primary neoplastic process is possible, but not all lymphoproliferation is neoplastic, and there can be immunogenic or infectious causes, right, of lymphoproliferation, lymphadenopathy, and a biopsy kind of showing something like this. And it's interesting that the the immunohistochemistry and cytometry was non-diagnostic. I think Castleman's is a great thought, Yasmin, and I definitely, I feel a little bit antsy not having ruled out EBV and CMV. I think those tests definitely have to come probably pretty early in a syndrome like this to make sure you're not just dealing with a very common disease but a very uncommon presentation of it, as well as one that would be great to be able to diagnose and not have a more sinister explanation for the symptoms for the patient's findings. I think going back to the neutrophil predominant peripheral leukocytosis, it might seem weird to go back to that, but I just want to have explained it, and I just wonder if it is just reactive to the systemic stress as well as the sort of toxic milieu that results from any sort of tissue damage, and that includes hemolysis, right? Just sort of like the free radicals and all the other stuff that gets released. So I think it was important to consider that as a potential clue of more kind of bacterial infection, but in retrospect, maybe it was just not part of the primary process, but rather I think I don't maybe have the right knowledge or to kind of put it together and come up with a diagnosis here, but I think just as next steps, I would say definitely look for exclude herpes viral infections, and certainly enlist expert consultation in hematology. I'm trying to think. I don't know if doing a PCR for HHV, HHV, I always forget if it's 6 or 8 in multicentric Castleman's is potentially helpful as well, but I'd look into that. And yeah, I'm kind of I'm flaming out over here. Chat, do you think we can make a final push here and come up with a leading diagnosis, or should we just say we've had a good journey and let's learn from Sosen?
Okay, so the patient was given IVIG for 2 days, and 6 days later, his hemoglobin improved to 7.5. And then he was discharged from the hospital due to insurance purposes. And upon discharge, he was given methylprednisolone, folic acid, and neurabione. And 10 days later, he was followed up, and his hemoglobin was 9.6. And after that, we proceeded with the excisional biopsy. Anyone wants to take a guess on what was found on the biopsy? Okay, so the excisional biopsy was done on the left supraclavicular lymph node, and it showed classical Hodgkin lymphoma, nodular sclerosing subtype. And a PET CT scan was done for staging and showed hypermetabolic lymphadenopathy above and below the diaphragm. And then the patient was started on chemotherapy, and his hemoglobin improved to 11.6. So the final diagnosis is autoimmune hemolytic anemia as a manifestation of Hodgkin lymphoma. So as a teaching point for this case is usually autoimmune hemolytic anemia is seen with non-Hodgkin lymphoma and CLL. And it is rarely seen with Hodgkin lymphoma. And when it is seen with the nodular sclerosing subtype or the mixed cellularity subtype. And it is usually the presenting symptom for this disease. And that's it for the case. I hope you enjoyed it.
I certainly did, very much, and learned from it, and will continue to learn from it as I reflect about it. If I remember correctly, nodular sclerosing is is the sort of the smaller piece of the Hodgkin's subtypes, but that occurs in young, usually men, and it has one of the best prognoses too, right?
I'm not sure. I don't remember exactly, but I think so. I'm not sure though.
So that's good to hear that among the non-self-limited causes that it's the patient will likely have a good outcome with treatment too. But I'm trying to sort of think back and do a cognitive autopsy. Hodgkin's was not necessarily front of mind for me, and I wonder where I personally in my brain kind of got away from continuing to strongly consider a lymphoma. We often deal with this sort of dilemma of pursuing, like we all learned the textbook approach to diagnosing lymphoma is doing an excisional lymph node biopsy, right? And I'm curious actually for everybody sort of across the world or practicing in the US, like how often do you see that as a first step? Because I very rarely see that as actually being done. Could folks, if you do have any experience with this, could you share in the chat, like, just realistically, practically, just like happened with Sosin's patient, like, are they getting a core biopsy first, or are they getting an excisional, like, up front? Anyone? Yeah, well, oh wait, excisional or core?
I mixed it up, Zaven. I think when the approach is reasonable, I've always seen the hematologist really try and go for the excisional.
Gotcha. So yeah, maybe it's just my experience. Sort of the justification I've seen is that the immunohistochemical and sort of laboratory techniques with which we can pinpoint and identify specific tumor types with any old sample is the reason why potentially starting with a core biopsy and avoiding the more kind of involved in morbid excisional biopsy is that's the reason why, like, it's not that kind of textbook teaching is not done as much in practice anymore, but certainly a great demonstration of how there's you're gonna miss a lot of diagnoses in that. So I that's kind of one reflection I had. Yes. Well, what do you think? What did you most like? What are you taking away from this case?
From this, I think that the main clue for me personally was the widened mediastinum and then the lymphadenopathy. I haven't had the privilege yet to work inpatient, but back in Mexico as a consult, primary care consult, every patient with cervical lymphadenopathy and no signs of infection, I would definitely ask for a CBC to see what is going on in there and then send them to secondary level. But yeah, I think that what helped me the most was the widened mediastinum piece of information.
Definitely. Cool. Well, thank you everybody for joining. Thanks, Sosin, for presenting the beautiful case and for scribing and taking notes. And please, Anmol, if you want to kind of summarize your take homes from listening and taking notes, please let's learn from that.
Thank you for a great case, Austin. I loved the discussion. I learned a lot. To summarize some of the taking points, we initially had the chief complaint of the patient presenting with severe anemia. So when we have anemia in a female, we think about the genital tract. But when we have a severe anemia in a male, we have to think of the other causes, which can be the main reason. So we think about where he could be losing his blood. So we try to figure that out. If it's the GI tract which is involved, because of the increased incidence of colon cancers in young people. So were all the differential we were having in our mind. So it was important to know in the history if the anemia was acute or chronic, and MCV, which would be important to understand the etiology of the anemia. The another important thing is to evaluate if the other cell lines have also been affected, WBC platelets. If they have been affected, then we start thinking about the bone marrow to be the cause. So that was how we were evaluating anemia. Then we realized the patient also had widened mediastinum. Anemia plus widened mediastinum, we mainly think about mediastinal lymphadenopathy. So it started to think about the various causes which can lead to widened mediastinum, in this case, a mass or a lymphadenopathy, any aortic issue, aneurysm, or a neoplasia. Then we realized that this patient also has bilateral palpable cervical lymphadenopathy, which more emphasized the fact that the mediastinal widening could actually be the mediastinal lymphadenopathy. So cervical lymphadenopathy makes us want to look out for the other areas of body to see if it is systemic lymphadenopathy. And the anemia this patient had, it seemed to be secondary to a disease process in the body. And then we realized from the labs that LDH was high, bilirubin was high as well, haptoglobin was low, which made us think that it could be a hemolytic anemia. So we thought if there could be, if it seems to be acute, so we thought if there could be an infection which precipitated this hemolysis, then we thought that a PBF, then a Coombs test would be helpful in this case. The Coombs test actually came back both direct and indirect positive. And we thought that it could mainly be due to the autoimmune hemolytic anemia. And we thought that what could be the cause precipitating the autoimmune hemolytic anemia? It could be due to, again, a viral illness, any autoimmune disease, or a blood cancer. Ultimately, the cervical lymphadenopathy biopsy was done, and it was realized on the excisional biopsy that it was Hodgkin lymphoma, and which was causing the whole symptoms and the autoimmune hemolytic anemia. And then we just thought about the various subtypes of Hodgkin lymphoma to be the nodular sclerosing type, which was actually the case in this patient. And I think nodular sclerosing is the most common subtype of Hodgkin lymphoma. And then the other subtypes we have are lymphocyte rich, mixed cellularity, and lymphocyte depleted. And if I remember correctly, the lymphocyte rich has the best prognosis. And I think the lymphocyte depleted has the worst prognosis. So that I think summarizes the whole of the case. And I learned a lot, and I've got a lot of reading to do after this as well, because I have to learn a lot about Hodgkin lymphoma. Thank you so much.
Thanks so much, Anmol. That was great. Yeah, it's such a pleasure discussing with you. So, thank you for the amazing case, and I hope everybody has a great day. Steph is alive and well. All right. Take care, y'all.